Well, thank you for the invitation. I really like enjoying to be here and to explain more about the color TDI and the technique and the approach that we use. It's called a practical approach, so I'm going to try to make it as practical as possible, but first I really want to start about explaining the theory behind what we are doing. Myocardial performance index is the most common technique to assess fetal cardiac function at the moment. It's called MPI and we know it all. It is an index that combines diastolic and systolic time intervals and is measured with pulse wave Doppler, as you see in the first image. And in the newer studies, it's also with pulse wave tissue Doppler techniques, as shown in the images. MPI divides the isovolumetric time intervals and ejection time. That means that it uses the time intervals that blood volume enters and leaves the heart. So it's not the myocardial performance itself, but it's the blood that flows through the heart. MPI defines the isovolumetric time interval and injection time by the opening and the closure of the AV valves. In other words, it defines the time intervals that blood passes through the valves and stops passing through the valve. Disadvantages are that it's kind of difficult to obtain, especially for ultrasonographers who are not doing it daily or not doing it often. And it has only moderate inter-observer agreement rates. So that was why we were searching for another way to find assessment of cardiac performance of fetuses. Color TDI, it's a similar technique as the pulse wave Doppler, but it doesn't measure the blood flows, it measures the myocardial wall motion. A color code is superimposed on the grayscale, and by that, when you measure that, you get this image. And it shows the direction and the velocities of the myocardial wall motion. In this figure, you see that the one going down is the relaxation time. You see the two phases, the active and the passive phase, and the other one is the contraction time. We could possibly measure the MPI in this image because it's possible to extract the isovolumetric contraction time and relaxation time and also the ejection time as shown in the figure here. And in that way you can measure the MPI. The only thing is that this image, it doesn't really show the opening of the valves, it doesn't really show the blood flows, it shows the myocardial motion. So we were thinking, what else can we do with this image that maybe it's an easier approach for the image that we can obtain here? So we were thinking of a new approach because it's wall motion versus blood flows. If you look at this figure, what actually do we see? Well, we see with point A, it's the same as the last change of direction. It's actually the end of the contraction time. If you look at point B, the heart starts extending, first with a higher velocity, then a lower, and the end at point C, it's the end of the extension, so it's fully extended. Then at point D, the wall is moving the other side, so it's contraction time. First the high velocity and then the lower velocity until it's fully contracted. So what you see is just the ventricular wall motion. Again, it's not the same as that what you see in pulse wave Doppler for blood flows, because there you see the valve movements and there you see the blood flows coming. If you, for example, look at point E here in this image, that's actually the time that the valve is opening. That's actually the time that the blood starts flowing. So it's not the same as blood flows. It's a new approach to the same thing, actually. So what we were thinking, what can we do with this image? We can use what we see, and what we see is that there are clear points that the myocardial wall motion is changing direction. And by that you can define relaxation time, as we see here, and later on the contraction time. And these are very simple methods that everybody can see and use to measure the times that the wall actually is moving. But why should you choose this approach? Because everybody is using the MPI, we all know the MPI, why do you want to do something else? Well, we believe, or we know it's easy to obtain in daily clinic. For example, in our clinic, we use it in research patients, but we also use it in pathophysiology, like TTTS recipients. And I learned a relatively new colleague this technique because I needed someone for the inter-observer variability. And it was easy to learn it here, and we also had very good intra and inter-observer variability, as you can see in the table below. Next to that, of course, the clinical value of this new approach should be studied as well, because if it doesn't find sickness or pathophysiology, it's of course worthless. So we tried, and we are already busy with that in the TTTS recipients. I also had an oral poster about that one, and we can see differences in children who have decreased myocardial performance. But of course, we are going to keep it as practical as possible. So let's just look, how can we obtain this? How can we do this? It's not difficult. Everybody, well, most ultrasonographers, good ultrasonographers, can make a 4-chamber view. So what you want to do is make a 4-chamber view, make the heart as large as possible in your image so that the frame rates are going high up, and be sure that the heart covers most of the surface of your image. Then you can apply the color-coded TDI on it, and then you save a clip. And in a clip, it's a couple of seconds. So here are about 8 cardiac cycles in the clip. So you get this image. And then you can think, well, we need just one cardiac cycle to do the measurements. But I'll show you all in the machine later. And you can choose just one cardiac cycle, and in that cycle, you can, with the region of interest, you can research every part of the heart that you want. You can make a large region of interest, as shown here, that covers the whole heart, but you also can say, I'm more interested about the left side, or I'm more interested about the right side of the heart. But I think this is the time that we make it more practical, and we go to the machine. Okay, so I wanted to start with just a clip which is already a data set that I made on one of my research patients. You can see it's the 4-chamber view. Here it's the spine and the ribs. And here is the abdominal side. So this is the right side of the heart. This is the left side of the heart. This is the septum, and you see clearly the AV valves. I cannot show you the knobology, but maybe later on people can watch closer. So then we can go to the MPI software. This is the region of interest, and you can make it as large or small as possible. So you can, in this way, I'll let it contain the full 4-chamber view. Oh. And you can see here that there's 7 cardiac cycles, and they're looking all good to me, so I can just choose one to highlight. Start time. This is the contraction time that you see, and here it's in 2-phase relaxation time. So here we can say end time. So now we have 1 cardiac cycle, and clearly we can see the change of motion in the cardiac wall. Here it's the beginning of the contraction time, and there it's the end of the contraction time. And here is the beginning of the relaxation time, and here's the end of the relaxation time. And we can measure the full, well, let's do this, yeah. Measure the percentage by checking the whole cardiac cycle. So this is in the global heart, and our experience is that the global heart is the most easy part, because it's, of course, not difficult to define your region, because it's the whole heart, and the image is very clear. It's more difficult when you want to look at smaller parts of the myocardial wall. So let's try it on this one. We make the region of interest somewhere smaller, And then we can say, for example, well, we were here in the septum, and let's head this away. Yeah, that's better. If you look in the septum, it's a difficult one, but you can still recognize the contraction time and the relaxation time. We didn't investigate the septum yet, so I just go to the right side. Here you can see it's a little bit difficult sometimes to define where are the contraction and the relaxation stops. So I'll show you that if you define where it stops and you are moving the region of interest a little bit, that most of the points they stay the same, and that's why the inter-observer variability is very low, because you can place it a little bit different and still have the same mark the same times. Left side is more difficult in our study, and that's the same with neonatological ultrasound echocardiography. And here, if you want to make sure that you have the right place, you can also play the clip again so that you can see where you want to place the calipers, the region of interest. But in this case, the left interval is also possible to find. So this is a healthy fetus. And there the relaxation time is long. It's the mean is about 45%, and here it's even a little bit longer. So then I want to show you one of my clips of one of the TTTS recipients who developed a right ventricular outflow tract obstruction at time of diagnosis of TTTS. So this is the ultrasound I made at that moment that they came in with the diagnosis. It's a younger heart. This is about 16 weeks old. And there was no flow over the pulmonary valve. So we were very curious what would happen with the myocardial motion if we measured it. So again, let's first define. It's difficult for you to see, but I know the case. Here you have the spinal cord. Here it's the ribs going, and there's the abdominal side. This is the right side of the heart. This is the left side of the heart. So I always start with covering the whole, the global heart, as shown here. Because the heart is younger, it's sometimes, it's very well. I can see it very well. I define again one cardiac cycle to examine. Well, let's just take the middle one. Start time. Here we see the contraction time. Here we see the relaxation time. Oops. End time. So here again we have the cardiac cycle. Here we have the start of the contraction time. It's about here. It's the end of the contraction time. Then we have here the start of the relaxation time, as well as here the end of the relaxation time. And again, if you change the region of interest, the clearly marked points, they don't change with it. So you can, another user can make another region of interest, but still you would find the same measurements. And in this fetus, you can see that the relaxation time is shorter than the contraction time, which we found more often in these recipient twins in TTTS. And we can try as well to find a smaller region. Let's see if we found the right spot. Just above the AV valve, you can either lower the speed if you like to see it more clearly. And then, as I said, it could be more difficult on the right and the left side, so you just try to find the spots where you can find the marcations of the relaxation and contraction time. It is more difficult, but this is clearly the relaxation time, which is shorter. And here's the end of the contraction time. And it's more difficult to define where it's here. So we can change the region of interest a little bit more. It's probably about here. The left side in this case is also easy to obtain. You can see here the start, end, start, end. So this is basically the technique as I wanted to show. I don't know if there are questions or if people, what we can do next, because
I think it's a good moment for questions before we show it on the system, or you can even try it yourself. If there are, yes?
The main action comes from the right heart in the fetus, but for HLH, you can make also prediction, I guess, with this step, potentially, or not?
For the left side. Yeah, exactly. Plus the linker. I think when you, because then the left side, it's the feasibility was about 75%, so it's quite high. So yeah, I think it will work in these cases as well. I didn't try it yet because I'm more focused on TTTS.
I'll bring you the microphone so we can.
Pardon, I put the same question than before in the presentation. And here probably we have a technician. What is the temporal resolution? But this corresponds to an M mode, okay? This is like an M mode for temporal resolution. And then this is a good resolution, but nevertheless, it depends. You are right, as you told before. This is the frame rate. We can see here frame rate about 100. So these are 10 milliseconds. And the short intervals are about 15, 20, 25 milliseconds. So in this small time interval, you could have a high error. How can you avoid that? How is it normed? How is it normalized?
It's a very good question about the temporal resolution. In fact, yes, the measurement points are at the actual, I will answer that question from technical point of view, sorry. The measurements are at the actual images, but because you have the interpolation, the actual usable time resolution is higher than that, is higher than 10 milliseconds. And there is a calculation to which you can calculate that temporal resolution.
And actually, it cannot be better than the frame rate because you use the frame rate for fixing and measuring.
Yes, but as you can see, you can recognize here on the display, because you have the interpolation of the data, the effective temporal resolution is higher than 10 milliseconds. So even if you are interested to, the shortest is about 20 milliseconds, that's the first part. What we would call in pulse wave Doppler, you would call it the isovolumetric contraction time. That's the shortest, about 20 milliseconds. Even that is possible to measure with that temporal resolution that you have. It will be higher than, or the resolution will be higher than 10 milliseconds, effectively.
Why?
Because of the interpolation.
Interpolation doesn't increase resolution.
It does, effectively, yes. But there is a measure to calculate that. I can explain to you later on in detail. But this is an effective way, which is very common in all kind of sampling methods, which allows you to do the resolution. And in fact, also, what you see over here is that it is not relying on the 20 or 22 milliseconds of the isovolumetric contraction time. It's more getting the relation between the systolic and the diastolic period. Because in a fetal heart under stress, the diastolic period is shortening. And this is actually not in the MPI calculation, but that's something which we see, and that's what you see also here in this example. If you compare it with the normal, you see that this period is shortened, and this is prolonged. So it's more about the ratio than the actual milliseconds itself compared.
Because if you make a ratio with short distances and the short distance has an inaccuracy, it will be translated to the calculation of the ratio.
Okay, but if that would be a problem, then they would not be in, they wouldn't have the sensitivity. In fact, if you look to patients and you do the measurement, you have very clear differentiation between the normal ratios and the abnormal ratios as they check.
Is a plant organ block, and then the plant organ block, the width of that will tell you that everyone.
That's what we did already. But I will look in my PC if I have it with me. Yeah, but it's a good question. I appreciate your concern, but in practice, it is not so critical for this kind of ratio, and that's a good thing. And the fact is that it's highly reproducible and easy to use. So it is really a very good function for the clinical daily routine. And typically, we try to get frame rates over 100 to be very effective. And this is a very good temporal resolution, which seems to work. Yeah.
Okay. Good questions, but let's focus on the patient. Let's see if we can scan this fetus real life. It's about 22 weeks pregnancy. So let's see if It's a little bit of wat is dwars in het Engels? Yeah, oblique. Yeah, the head is on the right side and the buttocks on the left side. So I'll try to obtain a four-chamber view as we know it. There it is. Then I'm going to make the plane as small as possible. So, child is having the hiccups. Now we have 171 frame rates, but if we use the TDI, it's about 132 frame rates.
This is a special setup for the MPI in the machine. This is a special setup we made for the MPI in the machine where you have the highest possible frame rate. That's not a setting where we would normally use for the fetal heart setting. Concentrate a little bit more on resolution. This is concentrated on frame rate.
So I made a couple of clips of a few seconds. Sorry. And then ja. Oh, waar is ze nou gebleven? Yes, I did. Kom ik daar naar bij? Ah, ja. So let's see on a clip we just made. Yeah, from here. So we are going to check the MPI again. And then we have even more seconds and even more cardiac cycles, and you can see the movement of the baby because you saw it when I made the clips, but you can also see it in the image here that it's drifting a little bit. But for the time intervals, it really doesn't matter as long as we find a good cycle to do our measurements on. So let's see, drifting a lot here. And I'm just searching for a good cycle. For example, here you see the relaxation time and there the contraction time. So we can take this one if we want. Start time and here end time. make it somewhere smaller to make it easier for us. Okay, so here you see the relaxation time clearly, and I can mark the beginning and the end, and here starts the contraction time, and there's the end of the contraction time. The spine of the baby was here, the abdomen was here. This is the right side of the heart, this is the left side of the heart. Let's start if we can also see the image on the right ventricular wall, just below the valve. And that's a little bit more difficult in this fetus. And again, I just try to find the right spot just below the valves. Should be there. And here you can see clearly the start of the contraction and the end of the relaxation and the end of the contraction. But it's more difficult to define where exactly the contraction time ends, I would say here. And this would be the relaxation time, and this would be the contraction time. If you go on the left side, in this fetus it will be very difficult. But we can try. And here you see the image changing a lot, and it's probably because it's just too difficult to obtain here. Any questions about this, or maybe people would like to join and try it?
Yeah, you're invited to try it yourself and see how it works. One comment about the MPI value. Of course, you did in a different order, so the values are a little bit strange, but you can use the default order to calculate the isovolumetric contraction and relaxation time, and then of course you have comparable values to the MPI values that you would expect, a little bit shorter because we measure different events. But that's the message of this measurement actually. We stick not to valve opening and closure because that is a pulse wave Doppler approach. In tissue Doppler we focus on the very interesting and marked peaks that tell the start and change of the contraction and relaxation periods. So we use the myocardial velocities as an indicator on tissue Doppler. That's where tissue Doppler is good. And taking that advantage, you get very high reproducible results. So that's the take-home message from this approach. Thank you very much. Thank you very much, Anna, for explanation.